Hello colleagues, are you hearing me? Everybody who is present, please write something in chat. When I see that you are present, I'll start lecture. Yes, okay, please everybody write name and number of group. I'll give you near 5 minutes to gather everybody who wants to hear today's lecture. Are you hear me? Do you see the lecture? Is there any technical problems? Do you see lecture? Are you hearing me? Okay, good. So firstly, I just want to remind you that with it in all lecture, yes, give you plus 1 point to your final mark, yeah. So it's better for you to not to miss lectures. And by the way, is someone from group 172B is hearing me? I want to remind you that tomorrow we start lessons offline in room number 6 of medical hospital that is on territory of medical academy. You know where is it? Group 172B. Are you hearing me? And we start our lessons at 8 o'clock. Uh, Please take with you clothes, I think Beckels and obligatory masks. Okay. Okay, colleague, let's start our lecture. So today we are going to speak about such very important and life-threatening topic as laryngeal stenosis. Yes, on the first slide, you can see 10 emergency cases in ENT, and with red color, the most emergency cases are marked. Yeah, and among these four topics, the uh, most important topics are laryngeal stenosis and nasal bleeding, because only these situations required from a doctor some of immediate actions. So what is laryngeal stenosis? Firstly, let's remember main anatomical details of larynx. Yes, as you know, laryngeal structure consists on cartilages, membranes, muscles, and mucosa. Yes, and as you remember, laryngeal cartilages are divided on three paired cartilage and three single cartilages. Two paired cartilages under paired cartilages we understand arytenoid cartilage, carniculate cartilages, cuneiform cartilages, and the single cartilages uh, are cricoid, pterygoid, and epiglottis. And on this picture you can see localization of single laryngeal cartilages. Yes, so here it is epiglottis. Yeah, this is one uh, shield of pterygoid cartilage, and this is cricoid cartilage. Yeah. What else cartilages we can see here? Yes, it's cuneiform cartilages and something here we can see arytenoid cartilage. So also we can see here ligamentum, cricoteroidum or conic membrane, and about this membrane we will speak later. And here, yes, you can see paired laryngeal cartilages. Yes, as we say, carniculate cartilages. Yeah, and the main aim of these cartilages is the point of fixation of vocal cords. And here we can see arytenoid cartilages. Here it's cuneiform cartilages. It's some kind of additional cartilages to make a framework of larynx stronger. Laryngeal membrane. There are several membranes, yes, but the main membrane from the clinical point of view is pterygoid membrane, yes, that fix pterygoid cartilage to hyoid bone, yeah, and cricoteroid or conic membrane that is localized between cricoid cartilage and pterygoid cartilage. Levels of larynx. Yes, larynx is divided on three main levels or parts. It's supraglottic, or vestibulum of larynx, its middle, the glottis or vocal rim, and subglottic space that is localized between the inner surface of vocal cords to first trachea rim. Yeah, so here we can see subglottic subvocal space. As you know, larynx has some functions, and main functions are respiration, phonation, and protection of lower airways. How does it work? Yes, respiration is understandable, yeah, that only through larynx air appears to move to lower respiratory tract, yes. And if we see on this picture, you can see that all air that person breathe in, yeah, move through this quite narrow space, yeah. And that's why any problem in this zone that lead to narrowing this space lead to problem with breathing. Phonation or voice producing, it's the second very important function of larynx, because speech differ the human being from animals, and if the person can't speak, yeah, it lead to problem with his social working, yeah, with his social connections. And what about protection of lower airways? Yes, you know that, for example, yeah, epiglottis during eating move in special way and close vocal space, yes, vocal rim from the food, yeah, from the substances that we eat. And if for some reasons this food appears in larynx, yeah, it can lead to some quite severe problem, yeah, starting from the fulminant stenosis of larynx, yes, if the piece of food blocked vocal rim, or if, for example, if person breathe this food in, yes, it can lead to problem with lower respiratory tract, yeah, starting from the bronchitis and ending with the obturation of one of the main bronchus, and it of course will lead to atelectasis. So how we can investigate larynx? Of course, it is better to use modern equipment for these purposes, so-called, for example, optic laryngoscopy, yeah, with rigid or flexible laryngoscope, yeah, and this allows us to estimate, to see the natural picture of larynx, yeah. But also, unfortunately, some clinics and some countries can't use this equipment for different purposes, and also we can use for this so-called indirect laryngoscopy. What is this? Yes, it is situation when we use special mirror, laryngeal mirror, yeah, to see the reflected image of structures of larynx. Yeah? So why it is called indirect? Yes, because we see reflected imagination, reflected view of larynx, reflected in this mirror. And what we can see during this investigation? Yes, we can see epiglottis, we can see subvocal space, the trachea rings, we can see true vocal cords, false, false vocal cords, arytenoid cartilages, it's so-called arytenoid epiglottic fold, and all of these are anatomical landmarks of normal larynx. Yeah? Here we can see direct laryngoscopy. Direct laryngoscopy is provided usually as intubation of larynx, yeah, and special tube, yes, as laryngoscope is introduced in larynx, yeah, and we can see also vocal cords here in the inferior parts of larynx. You can see intubated tube, yeah, and these methods of investigation usually used during operations on larynx, yeah, and as we spoke about, yeah, it's optic laryngoscopy, yeah, and here you can see all above mentioned structure, yeah, so it is epiglottis, it is arytenoid cartilages, yeah, it's vocal cords, true vocal cords, false vocal cords, ventriculus, uh, arytena epiglottic folds, it's piriform sinuses, yeah, and here we can see entrance to esophagus, yeah. So yes, again I want to remind you that during eating, when we swallowing the food, the epiglottis close uh, vocal cords, yeah, close vocal rings to prevent introducing the food into lower respiratory tract. No, yes, here is the image from the fiber transnasal laryngoscopy. Yeah, when laryngoscope is introducing into nose, yeah, and then move lower to larynx. So, what is laryngeal stenosis? Laryngeal stenosis is a narrowing of laryngeal space, which causes difficulty for air passing through the larynx rapidly or gradually progress. Now I just want to show again you this picture, yeah, for you to understand how narrow larynx is, yeah, and how easy, yeah, some processes can block air passing. So according to development time, laryngeal stenosis can be divided on fulminate, acute, subacute, and chronic. Please remember this classification because it is frequently asked on practical lessons. So, what is fulminant stenosis? Fulminant stenosis, it is a situation when asphyxia comes within several minutes or even seconds. Yeah, and the main reason for this can be foreign bodies or laryngeal spasm. Yeah. So, and here you can see different types of foreign bodies. Yes, for example, in this case, it's some needle, and in this case, it's more possible, yeah, that it can be laryngospasm in this case. Quite often, foreign bodies that lead to asphyxia, it's the quite big parts, for example, of meat, or it may be some toy, yeah, and the most cases of asphyxia due to foreign bodies, yeah, we can see in child, yes, because child can something breathe in or just take something big in mouth and it can block vocal rim. Or quite often it can be situation when some adult, for example, under some alcohol influence, yeah, and so when he can't control his process of swelling, or for example he breathes in during swelling the food, it can also lead to blocking of the piece of food in this region, yes, in vocal rim, and it, of course it can lead to fulminant stenosis. And you must understand that fulminant stenosis, it is the worst situation among stenosis, because you have very small time, yeah, to do something to save a patient. In this case, for example, stenosis that develop during some long period of time, they adopt to this condition, and usually we have no time in this case to help a patient. So, acute stenosis, yes, the obstruction develops from several hours up to 24 hours, yes, and what are the main situations that lead to this form of stenosis? It is allergic edema, or as you know, it's called Quincke's edema. Some inflammatory disease, false group, epiglottis, pontopericarditis, neck phlegmon, traumas, gunshot injury, thermal or chemical burns, or just kicking on the neck region. Operations, paralysis of recurrent nerve caused by stromatectomy. Yes, stromatectomy, you remember, it is removing of thyroid gland. And sometimes traumatic bronchoscopy or intubation of trachea. Later we will speak, yes, about some reasons of acute stenosis. So now I just want to remind you that among all of these reasons, the most common are allergic edema and inflammatory diseases, especially false group and epiglottis. And on this picture lower here, you can see, for example, as an example, such disease as epiglottis. Yeah, so epiglottis, it is inflammation of epiglottitis. Yes, epiglottitis, it is inflammation of epiglottis. If you anytime is going to make some test to, for example, sorry, I'll just see to confirm your knowledges, yes, in your country. Very often it will be test about röntgenological diagnostic of epiglottis. Yes, and here you can see so-called thumb sign. Yes, thumb, it is thumb. Yeah, thumb sign, it is very pathognomical, very character symptom of acute epiglottitis. Yes, it is the increasing of epiglottis. So, subacute stenosis. Subacute stenosis progresses during several days, usually until 1 week. For subacute stenosis, all pathogenic factors are real as for acute stenosis, but additionally it can be laryngeal diphtheria. And chronic stenosis, the obstruction develops slowly for weeks, months, and even years. Yeah? Usually it's any kind of tumors as benign, so malignant tumors. Also, it may be some specific infection of granulomas and scarring deformations. Remember that the most common tumor for childhood is papillomatosis, and for these patients it's a very, very big problem because papillomatosis is mainly has recidivic duration, and very often such patient requires several operations during their life. Unfortunately, in our countries, the main reason for stenosis that we see in clinics, and the main reasons for stenosis that bring to hospital by emergency, it's malignant neoplasm. Yes, it's malignant tumors of larynx. Of course, it is problem and it is not very good situation, because it means that diagnostic of such conditions are on proper level, but it's real situation for us. And Also, don't forget about scar and deformation, about after acute contropericarditis, traumas, and bones. Pardon 1 second. Pardon, let's continue. Scar and deformation are very let me see how this, what is in English. Is very insidious disease because unfortunately not every doctor even remember about this disease, and quite often it is even difficult to make a proper diagnostic for this disease, especially if additional methods of investigation such as flexible, for example, laryngoscopy or methods of visualization such as MRI, CT scan is absent. Yeah. So what is scar and deformation? Scar and deformation is the narrowing of larynx with scar tissue, and this scar tissue can develop. The most common reason for this formation is prolonged intubation of larynx, or sometimes also it can be a complication of tracheostomy. Why it is insidious? Because during, for example, indirect laryngoscopy, it is sometimes very difficult to see it, especially if it is localized under vocal cords, yes, in subvocal space. And in this case, we can use only complaints of patients and anamnesis data. So don't forget about scar and deformation as a reason for laryngeal stenosis. And what about specific infectious granulomas, tuberculosis, Lewis, and scleroma? But nowadays it's quite rare, but it also can be met, especially tuberculosis granuloma. So, what are the main symptoms of laryngeal stenosis? It's also, please point it in your mind and use this information during your practice, even if you are not going to work as an ENT specialist. So, main symptoms of laryngeal stenosis. Firstly, it's inspiratory dyspnea, heavy and prolonged expiration. Yeah. So you remember that inspiratory dyspnea, it means that a patient have a problem with breathing in. Yes, it is difficult for him to make breathe in. And please also remember that inspiratory dyspnea is the corrective system only for laryngeal stenosis. In all other cases, it will be mixed dyspnea or expiratory dyspnea. And the next symptom is neck and thoracic muscle participate in the act of breathing. So it means retraction of supra and subclavicular fossa, jugular incisura, and intercostal space. You understand that when you breathe free, yeah, so these muscles works in their physiological way, yeah. But if there is any narrowing of larynx, if there is any if there is any obstruction of larynx, of course we need to make a force, yeah, to pass the air through this obstruction, yeah, and it means that these muscles must work heavier, and it leads to retraction of supra and subclavicular fossa, jugular incisura, and intercostal space. And the third symptom is thyroid cartilage excursion. Yeah? It downwards at breathe in and upwards at breathe out. Yeah? So it means movement of thyroid cartilages and breathing, during breathing. Additional symptoms, it can be a lot of additional symptoms such as respiratory rhythm impairment, so respiratory inspiration delay, pauses between inspirations, reduced shortness of breath, laryngeal noises and stridor, voices changes, venous stasis, paradoxal pulse, and forced attitude and tilting back the head. And among of these symptoms, the most common and the most marked are laryngeal nose and stridor. And you understand that this stridor is produced due to passing of the air through the obstruction. Yeah? And voice changes is more common for a patient who has the problems on the level of vocal cords. So stridor and voice changes are the most common in the clinic of laryngeal stenosis. Stages of laryngeal stenosis, yes. So laryngeal stenosis has four clinical stages. Why we must know the stages? Because the management of patient strongly depend on firstly the reason of stenosis and secondly the stage of stenosis. So first stage, it's so-called compensatory stage. On this stage, inspiratory dyspnea can be revealed during physical exertion. Reduction or loss of respiratory pulse, level of CO2 increases, blood saturation with oxygen is normal. Unfortunately, on this stage, patients are very rare, can be diagnosed. And because if you read carefully these symptoms, yes, you can see that all of these symptoms may be except of CO2 level, can be met in everybody, especially during some physical exertion. The second stage, it is the stage when if the patient come to us, we can make a proper diagnosis, yeah, because on this stage we can see inspiratory dyspnea during moderate physical exertion. Also, we can see deep respiratory exertion with additional muscle participation after physical exertion, retraction of supraclavicular fossa and intercostal space, nose wings enlarged, yeah? And in blood, we can read hypercapnia. Usually in practice, it look like how patient comes to us and says that previously he or she can go on the second floor or the fifth floor, or he can he can walk freely, I don't know, as much distance as he or she wants. But nowadays, after walking for some period of time, or if he go upstairs, he appears this dyspnea, and he or she requires rest after this physical exertion. Yeah, and during this physical exertion, we can see this retraction of supra and subclavicular fossa and intercostal space. And also during this physical exertion appears deep respiratory excursion of chest. And for prognosis, it is better to reveal, of course, it is better to reveal such patient on the first stage, but commonly such patients appears on this stage or on the third stage. It's the stage of decompensation. On this stage, we can see marked inspiratory dyspnea even in rest. So even slight physical exertion lead to such dyspnea. Very often stridor or noisy breathing, rapid retraction of supra and subclavicular fossa and intercostal space, thyroid cartilage excursion. The patient is nervous panic, marked pale, cold sweat, then acrocyanosis, breath become rapid and superficial, hypercapnia and hypoxemia. On this stage, we have less time to help a patient, and this stage very often required surgical management of such patients. And experienced doctors very often can make a diagnosis, even don't see on patient, but listening how he or she is breathing on distantly, yeah, and such patients will have very marked stridor, yeah, and this stridor can be heard on distance. And the last stage, the fourth stage, the terminal stage or asphyxia. Yeah? It's apathy, drowsiness, fainting, decreasing body temperature, pupils are extended. Marked cyanosis, reducing heart activity, respiratory movements are superficial and faltering, change stocks, types of breathing, loss of consciousness, and death. And unfortunately, on the stage of asphyxia and terminal stage, very often we have no time to save a patient. Here just you can see how changes levels of carbon dioxide and oxygen level in blood during progressive of stenosis, and you can see also breath movements and rate of heart beating. Also, please just take in attention that normally breath movements per minute, yes, is 12, 18 on compensatory and incomplete on compensatory incomplete decompensation and decompensation. The rate of breath movement increase, and on the last stage the breathing movements become very rare, and also is about heart beating. Yes, so what about foreign bodies of the airways? Yes, you see that children under 3 years make 73% of cases, yeah, unfortunately. And if you have small children, please be very careful with small toys, with small pieces of toys, with Lego details, with food, yeah, because all of this can lead to very dramatic situation, yeah. What are the clinical manifestation of this situation? Yeah? So initial event coughing, choking, gagging, airway obstruction may occur immediately. So if after episode of ingulating of foreign body, if a child coughing, it's maybe good prognostic, yeah, because it means that this foreign body pass through the vocal cords to trachea or to bronchus. Of course, it's very also bad situation, but if this foreign body is localized here, usually you have a proper period of time to make some actions. And also in literature described some cases, yes, when a person, a child, yes, breathe in some solid part of something, yeah, and it stays undetected, yeah, and later such child may have or bronchitis or pneumonia, yeah, and during investigation it can be revealed a foreign body as a result of the disease. And if the foreign body pass through vocal cords to trachea and bronchus, it can be so-called asymptomatic interval, yeah. The foreign body moves down to lower airways and fixes in bronchus. And after the first episode of coughing, choking, yeah, the irritating symptom may reduce. And in this stage, the physician, as we said, may miss the possibility of a foreign body accident. But remember that later you may receive very dangerous complication as obstruction of bronchus, erosion with bleeding, infection with fever and cough, hemoptysis, pneumonia, and atelectasis. So keep your child aware of small pieces of anything. What we can do in the case of laryngeal foreign bodies? Of course, we must start firstly, and especially in children, it's quite effective procedure. It's so-called Heimlich maneuver. Yeah? On this picture, you can see the schematic image of this procedure. The main idea is to remove foreign body from larynx when the patient remove this foreign body by himself. But if you try of if few efforts of Heimlich maneuver is ineffective, we must do so-called operation as conicotomy. Yeah? So what is conicotomy? Let's return to the picture about anatomy of larynx. Yeah. Yeah. So what is conicotomy? Conicotomy is the cutting of conic membrane. Yeah, or another name for this membrane is cricoteroid membrane. It is considered that this place, this area, is is the place to what the doctor. It is the how to say. It is the most quick way to receive the access to larynx, yeah, to lower respiratory tract. And if we cut this membrane and introduce here special tube, we restore the breathing of a patient. Here you can see a few petals above tracheal foreign bodies and bronchial foreign bodies. How we can suspect tracheal foreign bodies? Yes, if a patient has choking and aspiration. Yeah? And to make a diagnosis, it's clinical and X-ray examination. Except of this, if we have some doubt about this situation, of course we must do fibrolaryngotracheal bronchoscopy and bronchial foreign bodies. History and physical examination determine the indication for bronchoscopy. So if a patient comes to you and says that after eating something he become to cough, and if there is some trigger and predisposable factor, of course we must do such patients bronchoscopy. Bronchoscopy in this case will be as diagnostic procedure, so and a treatment. X-ray examination of chest may reveal atelectasis of damaged lung and obstructive emphysema of healthy lung. Also, we can see shift of mediastinum in the damaged side during inspiration, so-called Koch-Jakobson symptom. And of course, the best variant if we suspect foreign body of bronchus is bronchoscopy. So, false screw. False screw is one of the most common reason of acute laryngeal stenosis for child. As you can see, firstly it was described in 1825, very long time ago. False screw or subvocal space edema and inflammation. Or in literature, this disease is go under the term acute laryngotracheitis. Why this situation happens? Firstly, it's about morphological factors. So what we can see during this disease in patient. Yeah. During false screw, we can reveal edema of subvocal space mucosa, we can reveal laryngeal spasm, and we can reveal gland secretion of laryngeal and tracheal mucosa. So, why children? Yeah, because of firstly small geometrical size. Yeah. The edema of mucosa on 1 millimeter in adult, yeah, decrease the space for breathing for 13%, yeah, and in the 1-year-old child, it's more than half of diameter of larynx. So it means that the edema that will not be clinically visual in adult give very strong clinic symptoms in child. Yeah. The second anatomical feature is abundance of areolar cellular tissue in the subvocal space, and the third is high rate of laryngospasm. And for laryngospasm also there are different triggers, including age of patient, according allergic disease, and including, of course, prematurity. Yeah? If the child is born before the physiological data. Yeah? Yeah, here you can see the predisposing causes for false screw. Yeah? It's age from 6 months till 3 years. More commonly, of course, it's the period from 6 months to year and half. Boys are affected more often, and some premorbid condition. Yes, it's acute respiratory viral infection. Spasmophilic diathesis, thrombolymphatic diathesis, exudative diathesis. No, it's allergic conditions. Yeah, rickets, prematally born child, artificial feeding up, condition after vaccination. No, condition after vaccination. No, it is not a premorbid condition, and overweight. And yes, remember that false screw, it is a viral disease, yes, and usually it's caused by para-influenza viruses. So what are the symptoms of false croup? Back and cough appearing suddenly at night. Uh, why in night? Yes, because at night the child is in horizontal position that makes edema developing in some vocal space wall, bad removing of inflammatory exudation discharge, and the vagus nerve acts mainly at night, and the gasp attack. And from my own experience, also very quite common symptom is stridor, yeah, noise breathing. It's maybe it can be the main symptom of this situation. So what we can do and how we can help a patient with false croup. Also take it in your mind, because everybody of you will have your own child and you must know what to do. The child should be taken on hands. Why? Yes, because when a child, especially when small child, little child, yeah, when he or she can't breathe, he become nervous, and this nervous can also increase irritation of vagus, and also child begin also to cry, and crying lead to increasing the edema. That's why the child should be taken on hands to make him calm, try to make him calm. Warm drink, try to relax the child and capture his attention, and some irritation reflex. If all of these methods are not effective, we must we must do and administer some drugs. Yeah, and the first drug and the main drug that is suitable in this situation is glucocorticoid hormones no, not intramuscular. By the way, it not concern our lecture, but general medicine. When general medicine, try to avoid intramuscular injection to child. Yes, in the whole world, intramuscular injections, as for child as for adult, is very rare. If required parenteral introducing of drugs, it may be intravenous or rectal, but not intramuscular. Yeah? So if the patient, if a child requires hormones, it can be administered in intravenous form, and in the case of severe stenosis, uh, uh, it is only one way for administration of these drugs. Don't afraid to administer high doses of hormones, because it help child very quickly usually. Yeah. Later, or if the symptoms of stenosis are not very severe, you may administer these hormones in form of inhalation. Also, antihistamine drugs must be prescribed, and if such child appears in hospital, usually the hydrating therapy will be administered, yes, to reduce edema. Spasmolytics, yeah, because we remember that one of the factor of this condition is laryngospasm. Antibacterial therapy not always antibacterial therapy and not from the beginning. Very important it is oxygen inhalations, and in very severe cases, if the stenosis is third or fourth stage, no, mainly on the fourth stage, yeah, or if the patient is not react to drug therapy. In this case, we can use prolonged nasotracheal intubation or tracheostomy or craniostomy. But in most cases, proper conservative treatment is enough to deal with this situation. Now, here you can see it's also more historical, yeah, mix for inhalation in the case of false group, because nowadays we have in drug stores, in pharmacy, the special drugs for inhalation. They're prepared inhalation drugs for this situation. But for example, if you have no access to drug, you may use such group of drugs to prepare a mix for inhalation. Laryngeal diphtheria. Yeah? Laryngeal diphtheria, you remember, it can be a reason for some acute stenosis. As you remember, diphtheria is caused by Corynebacteria diphtheria, and it is entrepreneurs disease. It means that only a human being can be the source of infection. It is quite dangerous disease, and for previous times before vaccination was used to prevent this disease, the level of death from this disease was quite high, yeah, due to several reasons. You remember that diphtheria is classified due to localization. Yeah, it may be diphtheria of pharynx. If diphtheria can be diphtheria of larynx, laryngeal diphtheria. It can be diphtheria of nose or diphtheria of other localizations. If we are speaking about laryngeal diphtheria, so we have 3 stages of this disease. The first stage is dysphonic, yeah, or stage of catarrhal inflammation. On this stage, usually body temperature decrease, cough, change of voice, last for 2-3 days. Unfortunately, on this stage, we can very rare establish the proper diagnosis because the pathognomic sign as membranes, yeah, are absent on this stage. Also, change of voice can be as a result of any other respiratory infection. And in a stage of stenosis, yeah, symptoms of laryngeal stenosis appear. Why this stage with symptoms appear? Because fibrinous membrane begin to form in larynx, yes, and these membranes block the vocal rim, yeah, and due to these membranes, patients can't breathe. and asphyxia stage, it is understandable what does it mean. Very important to differentiate, yeah, false group and laryngeal diphtheria, or another name for laryngeal diphtheria is true group. Yeah, so you can see the main clinical features of these diseases. If we are speaking about false group, it is more sudden development of the disease. Usually, previously the patient may have acute respiratory viral infection. And if we are speaking about laryngeal diphtheria, it is gradual development of disease, and quite often such patients previously have symptoms of quinsy, yeah, or acute tonsillitis. Speed of stenosis increasing, yeah, in the case of false group, it minutes, no, not minutes, but hours till a day. And in the case of laryngeal diphtheria, it's 1 or 3 days, so until the membranes become to produces by mucus. Usually in the case of false group, there is no intoxication or quite slight form of intoxication. And in the case of diphtheria, intoxication is quite big, and maybe also tachycardia. And one of the main symptoms, yeah, in the case of false group, the voice is kept, and in the case of laryngeal diphtheria, it's husky, voice up to aphonia. Because if you remember from the microbiology, Corynebacteria diphtheria has a special neurotoxin, and this neurotoxin affect nerves that take part in phonation. Also very important sign, it's the type of coffee. In the case of false group, cough is barking and increased the stenosis. Yes, that's why it is very important to try to make a child calm. And in the case of laryngeal diphtheria, the cough will be very silent, and after coughing, the symptoms of stenosis may reduce, yes, if a patient coughing out these membranes. And of course, if we see in larynx, we can see edema in a case of false group, or we can see membranous coats in a case of laryngeal diphtheria. Prognosis, yes, or duration of stenosis. If we are speaking about false group, it can stop suddenly without any treatment, but if we will not treat laryngeal diphtheria, the patient will die. So, epiglottis. Epiglottitis. Epiglottitis is acute purulent inflammation of epiglottis. Due to statistics, it's also more common situation for child, but also can be met in adult. Under the scientific paper, very big role in epiglottitis play such bacteria as pneumococcus. That's why vaccination against pneumococcus can decrease the possibility of this disease. Yeah. So, what are the symptoms? The symptoms include acute pains in the throat, difficult breath, and usually high body temperature. It's also very insidious disease because usually a patient with sore throat, yeah, with pain in throat, firstly come to general practitioner, yeah? And when a general practitioner look at pharynx, yes, he can see he may see no pathological changes in pharynx. Because to see the epiglottis, yeah, minimum you need to do a direct laryngoscopy for this patient. And if the doctor don't take in his mind, don't remember about such disease, yeah, he may not to administer proper treatment. And if the proper treatment will not be administered, it can lead to increasing of epiglottis in size and blocking the vocal rim, and it can lead to stenosis. Here you can see so epiglottitis has two main forms of disease. It's so-called catarrhal form and purulent form. Purulent form when we can see the pus dots on the surface of epiglottitis. And of course, in this case, the proper treatment include cutting the abscess of epiglottis and proper medicamentous treatment. And also remember one thing, that conservative management of all stenosis include mainly 3-4 types of drugs. On the first place, it will be glucocorticoids in any case, and start with glucocorticoids in any case. The second group of drug, it will be antihistamine drug. The third group, it may be diuretics to decrease edema, yeah, and non-steroid anti-inflammatory drugs and antibiotics as options. Of course, if we are speaking about acute epiglottitis, antibiotics must be prescribed in any case as non-steroid anti-inflammatory drugs. So, first, if you suspect stenosis, in any case, start from glucocorticoids. I think about chronic stenosis we will discuss more in details during our lessons. And if our conservative, if our medicamentous drugs are not effective, so such patients are required in tracheostomy. Yeah? So what is tracheostomy? Tracheostomy is making an opening in the anterior wall of trachea and converting it into stoma with skin, and introducing in this hole a special breath or tracheostomical tube. Yeah? The main indication of tracheostomy is laryngeal stenosis in decompensation stage, so it means third stage. But sometimes if we suspect that medicamentous treatment will not be effective, for example, if we are speaking about chronic stenosis due to some tumors, malignant, yeah, we can do this operation on the second stage. And the second indication is prolonged artificial lung ventilation. And I want to tell you that prolonged artificial lung ventilation is the main indication for tracheostomy in the whole world, because if we have adequate diagnostic equipment, we must not allow a patient with a chronic form of stenosis to come to the indication of emergency tracheostomy. So, tracheostomy types, yeah? There are a lot of types of techniques of tracheostomy. It depends on the direction of cutting of trachea. It may be vertical, yes, it may be horizontal, it may be cutting of a piece of trachea ring, yeah. Also, it may be divided to superior, middle, and inferior, depending on which of what ring of trachea we cut. Yeah, if we are speaking about superior tracheostomy, so the cutting is between second and third ring of trachea, middle between third and fourth, and inferior between fifth and sixth rings. It's how like tracheostomic tube look like. It can be with cuff, it can be without cuff. If a patient requires prolonged ventilation, artificial ventilation, of course this tube must be with cuff. If the patient after treatment still require in breathing, but he or she can breathe by itself, this tube is without cuff. And as any operation, tracheostomy has a variety group of complications. Yeah, it can be a reflex cardiac arrest. The most common is hemorrhage. It can be subcutaneous emphysema, and these two complications is the most common. It may be pneumomediastinum pneumothorax. It may be formation of a false passage. It may be injury of anterior wall of esophagus, very unpleasant complication. It may be shock after hypercapnia, pulmonary edema, and purulent tracheobronchitis in postoperative period. Remember about conicotomy, conic membrane incision, yeah, and laryngeal intubation. So also remember about laryngeal intubation, because if we are speaking about acute stenosis, in most cases the best variant for help is laryngeal intubation, because almost all acute stenosis very good react to conservative treatment. So in a case of acute stenosis, we can avoid this operation. If we are speaking about chronic stenosis, if we are speaking about tumors or scar tissue as abstraction for larynx, of course, in this case, very often intubation is impossible, and this condition requires from us tracheostomy. And in a case of chronic stenosis, if the patient has no access to maybe high technological equipment, in this situation it's better to make tracheostomy earlier, yeah, to allow a patient to find the ways for treatment of, for example, tumors or scar tissue stenosis. And also here it may be indication for tracheostomy. Sometimes, due to some factors, it is impossible to intubate a patient. For example, after severe facial trauma, or if a patient can't open his mouth, and intubation through the nasal cavity is impossible. In this case, we also can do tracheostomy for artificial ventilation of this patient. It's how like laryngeal laryngotracheal tube is look like. Uh, it's on this picture you can see situation with post-traumatic cicatricial laryngeal stenosis. Yes, we can see the narrowing of vocal ring. And here it's complicated foreign body of esophagus that lead to cervical mediastinitis and neck phlegmon. Yeah, and in this case, their phlegmons, the purulent process with abscess and phlegmon formation on neck also may be indication for tracheostomy. On this slide, I want to finish the current lecture. If you see some questions, you may print here on chat. If there is no question, I want to remind you that visiting all lectures allow you to get additional point to your final mark. And I want to remember that tomorrow we start offline studying with group 172B, and we meet at 8 o'clock in St. Luca Hospital on the territory of Medical Academy. So good luck, and we will meet with group 172B tomorrow.